Seperti yang kita semua maklum, hari ini ada sesi berkaitan ceramah pendidikan kesihatan anjuran oleh Unit Pendidikan Kesihatan PPUSMB IPPT. Ceramah ini bertajuk untuk hari ini adalah Approach to Hemolytic Anemia, yang mana penceramah adalah Dr. Hafizudin Mohamed Fauzi. Beliau adalah pakar hematopatologis di CDL, Klinikal Diagnostic Lab PPUSMB. Okay. Memandangkan attendance kita mungkin tak ramai lagi, mungkin kita start tunggu lagi 5 minit macam tu lah. Kemudiannya kita start dengan sesi ceramah untuk petang ni. 5 minit lagi untuk tunggu rakan-rakan yang lain join. Dan mohon juga para attendees untuk mungkin mutekan speaker masing-masing semasa sesi ceramah ini berlangsung. Kalau ada soalan boleh type di chat box ataupun kita buka sesi Q&A towards the end. Saya rasa kita mungkin boleh habiskan somewhere in between 3:20 kot untuk bagi 10 minit Q&A session macam tu. Okey ke Dr. Hafiz?
Boleh.
3:20, 3:10 macam tu lah.
Suara saya, kalau saya jatuhkan speaker ke bawah, saya tak pegang, dengar jelas tak?
Jelas. Kami dengar jelas tu.
Okay, sekarang jelas Sebab kalau tak jelas, saya kena pegang mikrofon tepi mulut.
Okay, kita tunggu rakan-rakan yang lain sementara tu. Kita lagi 3 minit lah, kita start. Maksudnya 2:38.
Sekarang 2.35 kan?
Okay, Assalamualaikum semua. Tadi saya dah inform, basically kita start 2:38. Memandangkan attendees kita, kalau tengok kat sini 13 orang, mungkin kita boleh start lah Dr. Hafiz
Kita dah record kan anyway. Boleh
Ya.
share jugalah kepada MO yang tak ada. Alright. Okay. Nak saya start sekarang ke?
Ya, boleh. Bolehlah kita mulakan sekarang. Lepas tu kita pukul 3.20 macam tu ataupun 3 suku, kita buka sesi Q&A kalau ada soalan. Kalau tak nak bertanya secara verbal pun boleh type di chat box.
Okay. Okay, Assalamualaikum semua. Perkenalkan diri saya Dr. Hafizudin bin Mohamed Fauzi. Saya hematopathologist di IPPT dan selaku medical lecturer juga di U56. Okey, pada petang ni saya diberi tugasan untuk bercerita sedikit tentang approach to hemolytic anemia. Ini tajuk kita lah pada petang ni. Kejap. Okey. Okay, this is the contents of my presentation. When we talk about approach to hemolytic anemia, so approach means starts with history, physical examination, laboratory investigation, and management. And after that, along the way, we'll be discussing some of the causes about IHA. Okay, I'm not going to talk everything about causes of IHA because this is only 1 hour session. Because, you know, if we want to talk each diseases, it takes more than that to explain. So as you know, overall, you need to know the causes of IHA. If you don't know the causes, then how you're going to treat it and how you're going to detect the symptoms, right? So you need to know the causes first. So as you know, hemolytic anemia can be divided into hereditary and acquired. And acquired can be divided into further immune and non-immune. Okay, when we talk about immune, it's something involved antibody antigen reaction. Okay. So for hereditary examples like membrane disorder like hereditary spherocytosis, hereditary erythrocytosis, this is something wrong with the membrane of the red blood cell and causing the red cell becoming round, which is spherocyte, and erythrocyte, which is like, you know, membucur. And we also have enzyme disorder like G6PD deficiency, PK deficiency. This is genetic inherited, and you know, when there's insult to the RBC, so they will lyse. And also we have hemoglobinopathies, like sickle cell disease or unstable hemoglobins. Bear in mind, these G6PD and sickle cell disease, they only become hemolyzed when there's insult, like for example, infection or something exposed to certain drugs, then they hemolyze. Under normal condition, when there is no insult, they can live like normal people, and the RBC morphology looks normal. Okay, for acquired cause, this is the most important thing, because it's daily encountered in routine practice. Like immune, we have autoimmune. Autoimmune means autoantibody, right? It can be divided into warm or cold IHA. And we have alloimmune, means the antibody developed from the stimulus from the outside the body, which is, example is hemolytic disease of newborn, hemolytic transfusion reaction, post-allogenic stem cell transplant, and also drug-induced. Okay, this involving antibody. For non-immune, the examples like infection, right? Malaria, where it direct lyse the RBC, so it doesn't involve any antigen antibody reaction, right? So we have also mechanical like prosthetic heart valve, PNH, TTP, HUS, hypersplenism, oxygen substance, DIC, severe burns, extracorporeal circuits, and also renal failure. This is all non-immune causes that can cause hemolysis. Okay, so that's why to know or to detect a hint what are the causes of the IHA, you need to get it from history first. History, and then proceed with physical examination and investigation. So that when you have overall picture, then we can pinpoint which one of this is the causes. Okay, so that when you know the causes, you know how to treat. Okay, So, for hemolysis, in general, it can be divided into intravascular, which happen inside the blood vessel, and extravascular, is outside the blood vessel. The intravascular red cell lies in the circulation and release their product into the plasma fraction. Patient can have anemia because of the lives of the RBC, decreased haptoglobin, hemoglobinemia, hemoglobinuria, urine hemosiderin, and increased LDH. And extravascular is the ingestion of red cell by the macrophages in the liver, spleen, and bone marrow. The lysis of the RBC doesn't happen inside the vessel. Little or no hemoglobin escape into circulation. However, patient having symptoms anemia, same like intravascular, decreased haptoglobin and increased LDH. So all this you can find out in the biochemical investigation, which you can send to the biochemistry lab. So we start with history. So you need to detect is patient hemolyzing and is there any symptom and signs that you can get, like unstable vital signs, heart failure, spectrum of symptoms related to underlying disorder, jaundice, spleen or liver enlarged, lymph node, and also look at the urine and the skin. So for the jaundice, usually it becomes prominent under the sclera of the eye when the total bilirubin more than 40, right? And then when you look at the liver function test, you look at the total bilirubin more than 40, and you have to look whether what is the predominant. Is it indirect or direct? For hemolysis, usually it's indirect. Intravascular hemolysis is the indirect. If direct, it's more towards liver problem. Okay? And then you need to find the risk factor. What is the risk factor that might expose patient to hemolysis? IHA, right? Hemolysis. So we need to look at the age. Age also can give a clue. Like when patient presented with older age, you need to bear in mind. Old people tend to have diseases, chronic diseases, malignancy. For example, in chronic lymphocytic leukemia, like CLL may presented with IHA, right? IHA is just a presentation of CLL. That's why when you have IHA, you encounter IHA, you need to look for the causes, especially elderly. Look at the lymphoproliferative neoplasm or malignancy. Okay, and then look at the patient job. Uh, Try to see what their working environment looks like. That might give clue. Maybe they are exposed to certain toxin every day that can induce hemolysis, right? Underlying illness, patient having chronic disease like autoimmune diseases, malignancy or infection. These can induce hemolyze to the induced antibody that hemolyze the RBC. And also, of course, drugs. Later we will discuss which are the drugs that commonly associated with hemolysis. So then, when you taking history and physical examination, do examination, you suspect there's hemolysis, of course, you need to support your differential diagnosis with investigation. So as usual, the basic investigation that you send is full blood count. And you need to take plus differentials and plus retic. That's the complete set. If you take only full blood count, it doesn't give like a overall picture to diagnose hemolysis. Like from blood count, what we can say? We can see normocytic normochromic anemia. The MCV and MCH is normal, right? Maybe this is the bleeding and blood loss. In cases of warm IHA, sometimes we can look at the parameter and can predict what type of IHA is it. Like you look at the MCHC level. It's more than normal range, more than 36. It indicates that maybe there is the presence of a lot of spirocytes, right? So when there's a lot of spirocyte, it is usually associated with warm IHA because in warm IHA, the majority of the morphology in the peripheral blood film is spirocyte. So you could see MCHC more than 36. It's not really normal. In cold, how about in cold IHA? In cold IHA, there is an agglutination of the red blood cell. So we expect when the RBC agglutinate, the size will be bigger. So that's why when you see the parameter MCV, it shows higher than normal range, more than 100 picogram. So it shows that there is a big cell, and MCHC also high because of the group of RBC. Concentration of the hemoglobin will be higher. Okay, These are the clue that you need to see when suspecting hemolysis. And then if you tick red tick, there is a channel which is run together with red tick channel, which is the red P value. If less than 27, it indicates for high specificity and sensitivity that patient might have IDA. So when patient have less than 27, sometimes you don't expect, the MCV and MCV will be lower than expected if they have concomitant IDA, right? And the retic also not responding to the hemolysis because there's no iron enough in the body. So this is need to be in mind juga lah, whether patient having IDA or not. You need to have a consideration of that. And then look at the FRC. This is all the extended parameter that you can find in the whole blood count from the SysMap machine. Provided you tick retic. When you order, you tick retic, then this will come out. So the fragmented cell, we can measure whether there is a lot of percentage of fragmented cell in the blood. If more than 1%, it's quite significant. Maybe patient having MAHA, the IVC, that might cause, that pinpoint the causes of the hemolysis. And then, of course, you look at the retic. Retic much usually higher than 1%. Normal is 1%. But bear in mind, in acute phase, the retic might not reflect the true situation because it takes some time for the retic to respond. So when you find normal retic, it doesn't necessarily tell you that it's no hemolysis. Okay, sekejap ada phone agent.
Setakat ni para audiens okey ke? Boleh, suara jelas macam tu
Okay. Maaf tadi ada urgent call I kena jawab sekejap. Tak apa, I dah cakap I akan call kemudian. Alright, right, okay. And then that's why I asked you to pick for differentials because we want to look at the neutrophil, whether it's neutropenia or neutrophilia, because both condition can give clue. Usually in blood loss, in bleeding, there is a reactive neutrophilia or can be also neutropenia. Okay. And then look at the platelet. Platelet may be low. Boleh dengar ke Salmah? Boleh dengar ke suara saya?
Boleh Dr. Hafiz.
Okay.
Cuma mungkin kena campur BMBI sikit kot.
Oh, ya ke?
Ah.
Okay. Platelet may be low, maksud rendah. Maksudnya maybe low than normal range because we expect there could be peripheral consumption. Maksudnya bila ada blood loss bleeding, there is a platelet consumption to seal all the blood loss atau bleeding of the hemolysis tu. And or it could be high due to reactive. Maybe there is an infection that induce the hemolysis. The platelet can be also high, reactive towards the inflammation or infection. Okay. So like I say, note that at the MCV is the volume of the RBC, MSH is the color. The MCV, MSH value and retic response depends on the underlying available iron. If patient having severe IDA, of course you would not see retic response, good retic response, and MCV, MSH would be lower than expected. Okay. Okay. Okay, that's for full blood count, differential and retic. Ada yang kalau tak faham boleh type, kita akan jawab kemudian lah ya. Okay, then that is full blood count. And then, of course, you need to send full blood picture. Why you send full blood picture? This is indicated because I want to look whether there is evidence of hemolysis and other risk factor, for example, malaria inside the RBC to pinpoint what is the causes of the hemolysis, right? So that's the purpose of you sending FB. For example, in this smear, you see what? What can you see? There is a lot of spirocytes. A lot of spirocytes. This is the rounded, well-concentrated small RBC. This is usually seen in cases of warm IHA. All right. So what do you expect from the full blood count parameter of the MCHC? it should be high, because there are a lot of mean corpuscular hemoglobin concentration is high, because they are concentrated hemoglobin inside. And then what else you see? You boleh nampak this bluish thing. This is bigger than the normal RBC, and it's a bluish thing. This is the polychromatic cell, reticulocyte. We call polychromasia. If it's more than 1%, we call polychromasia. So this is a good rapid response towards the hemolysis. Right? This is cases of warm IHA. And how about this slide? From this whole blood picture, you see the RBC agglutinate, bergumpal together like anggur, like a grape. So this is example of his cold IHA. That the other one is warm. This is cold IHA, right? And this another case of malaria infection. That's why sending AVP is crucial to know the causes. Sometimes patient travel inside the jungle. That's the question you need to ask the patient, right? So when you see inside there is a malaria this is inclusion body, malaria. So they likes the RBC. And how about this? This is the normal RBC with central parallel, and you see this triangle sharp angle, right? This is all we call fragmented RBC. When in one field there is a lot of this cell, we call maybe patient having MAHA, microangiopathic hemolytic anemia. Could be TTP, HUS, right? So we need, this is just giving you that it's a fragmented RBC. So whether it's TTP or HUS, you need to relate with the clinical presentation and other investigation. Okay, so you need to know each diseases like TTP, HUS, what the causes, what the symptoms, what the laboratory investigation to diagnose them. Because this is the further investigation test that you need to send after looking at the finding from the FBP. Okay, other tests that you can send is coagulation profile. Is it PT and APTT prolonged? Because when there's prolonged, could be the IVC. So when you're having the IVC, you need to find the cause. Is it infection that causes the IVC? Right? So when you have the IVC, you need to treat the underlying cause. For example, infection, you give antibiotic, right? And then you treat accordingly lah, with the regime of the IVC. So in biochemical investigation, what do you send for the biochemistry lab? You send LDH. Of course, this is the most important one. One of the parameter usually is high, more than 1,000, because there are a lot of LDH inside the red blood cell. So, but bear in mind, higher LDH normal is about up to 300, right? Like, for example, higher than that, like 500, 600, you need to bear in mind, LDH has many sources. It can come from the liver, it can come from the other sides of, from the heart. So you need to correlate again with underlying disease. If patient having liver disease, heart problem, of course, this LDH might come from there. It's not solely from RBC. So again, when interpreting LDH, you need to consider relating it with the underlying patient's illness. Okay, so usually in acute event of hemolysis, when there are a lot of RBC lies with severe anemia, LDH usually, in my experience, more than 1,000. And then you look at the liver function test, looking at the total bilirubin, is it high or not? And then if it's high, more than 40, you need to look whether the indirect bilirubin will be high. So this is one of the supportive parameter to support hemolysis. Serum hemoglobin low, urine, we test for urine for hemoglobin and urine for hemosiderin. Usually hemosiderin will occur later a bit after the hemolysis, not in acute phase. So that's for hematology lab, biochemistry lab, and now to the role of blood bank. What you want to send? You should send direct test. Okay, you see whether there is antibody sensitized on the surface of the RBC. Okay, if the sensitized is positive, then we can grade it. We can grade blood the 82. Is it 1+, 2+, 3+, or 4+? Usually 1 or 2+ we call mild. Strong reaction is 3 and 4+ strong reaction. So after having polyspecific D80 positive, we need to proceed with monospecific, which is we want to identify whether what's the I think that attached to the RBC. Is it IgG? If IgG is indicating perhaps a warm IHA. If the C3D complement, usually 3D, we indicates more towards cold IHA. Okay, again, so you need to correlate this with the finding in the full blood picture. It could be mixed together. Okay, if patient having hemolysis from the history, from other biochemical investigation, but when you stand DET is negative. So there is situation where you need to consider IHA with negative DET. Yeah, it could be perhaps there is a low affinity of antibody towards the RBC membrane, or low level of RBC bound antibody, or it is another type of immunoglobulin, which is IgA, which is not tested. Alright? And okay, and also we if the AT is positive, we also do antibody screening lah, whether to see what type of antibody present, and blood bank will identify its specificity and of the antibody, because if patient require transfusion, we need to be negative antigen with the antibody. This is in the cases especially in LO LO antibody. Okay, okay, this is a bit about direct contrast. All right. This is how the blood bank do lah, right? This is the RBC. This is the antigen, and the green one is the antibody. So in the bank, whether we want to know there is DAT positive or not, we will add this AHG, anti-IgG AHG reagent, so that it will bound together the RBC that are sensitized with the immunoglobulin, the IgG. So the IgG weakly fixes complement, but the IgM strongly fixes the complement, the C3D just now. Alright. So in warm IHA, usually it involve IgG, and in cold IHA, it involve IgM. Okay. Just now, when you suspect hemolytic anemia, you do DAT. If DAT positive, there are 3 possible causes that should you bear in mind. First is, could be autoimmune hemolytic anemia. This is could be warm or cold IHA. It could be alloimmune hemolytic anemia, meaning antibody is triggered from antigen outside the body. And third is the drug-induced hemolytic anemia. So this is the most important first lah. But the AT negative, usually the other causes that we discussed in the first slide just now, like, you know, the acquired cause, which is the inherited cause, hemoglobinopathies. Infection is the acquired cause. Enzymopathies ni, this the inherited cause. Hydrospherosis is the inherited, and thrombotic microangiopathies like TTP is the acquired cause, which is giving DAT negative. But bear in mind, just now I say there is hemolytic anemia with DAT negative involving immune, involving antibody. So this is now that we discussed just now, hereditary. Recap again, we have hereditary, acquired, and acquired we have immune and non-immune. The immune is the autoimmune, alloimmune, and drug-induced. These are the 3 that we want to concentrate today. Okay. Okay, when you see DCT is positive, you need to ask question, right? There's a decreased red cell survival? Has the patient been recently transfused with red cell plasma containing product? Because it could be from the hemolytic transfusion reaction, right? The 3 causes that we discussed just now, this one. So if this could be transfusion reaction, right? Is the patient on any medication that cause positive DAT and cause hemolysis, like penicillin, aldomet, cephalosporin? So we can categorize this under drug-induced hemolysis. Has the patient received any transplant? This could be fall under category alloimmune hemolysis by ABO mismatch from the stem cell transplant. Is the patient receiving IVIG? This is a treatment, right? So when you give IVIG, this IG immunoglobulin will attach to the RBC, of course, giving DCT positive. Is the patient pregnant? And is the patient a newborn infant? It could be denoting hemolytic disease of newborn, right? So this same question that pinpoint the possible causes of DCT positive. And please note that a positive DET does not mean decreased red cell lifespan, and therefore a history and physical is needed to determine the significance of the positive DAT. Sometimes DAT is just positive, but it's not significant, right? And if there is no evidence of increase, I mean, the hemolytic workup doesn't show positive towards hemolysis, like there is no anemia, no increased reticulocyte, no increased LDH, no decreased haptoglobin, no hemoglobin, and no hemoglobin, no further workup of positive DAT is necessary because it's unlikely hemolysis. Maybe patients do not have any symptoms of hemolysis, do not have symptoms, do not have sign, like medication also do not support, then further necessary investigation might not be needed. Maybe this is the unsignificant DAT positive. Just bind to the RBC doesn't do anything to it. Okay. So this is the diagram to show you what the blood bank will do. This is the antibody on the RBC membrane, right? Like Rhesus, MAS group, Lutheran, Lewis, Kell, Duffy. So the blood bank will identify the antibody that attached on the RBC here, and once they will slash here and there, and at the end we can get the specificity of the antigen of the we can get the specificity of the antibody towards what's antigen. So if Cal is detected, then meaning that there's a antibody Cal present. So we need to give red blood cell, which is Cal negative, to the patient, because patient is having antibody towards Cal. Okay, why you want to identify the antibody? Because you want to determine the specificity of the antibody to provide antigen negative blood to the transfusion, to determine clinical significance, and investigate the hemolytic disease of newborn, and to investigate the transfusion reaction. Right? We want to know what is the name of the antibody, what is the culprit that causing the hemolysis. Okay, now we come to the difference between warm IHA and cold IHA. So usually warm IHA, the optimal RBC binding is at the body temperature. So our body temperature is 37. So that's why it's easily hemolyzed. Because the antibody react optimally at our body temperature. But for cold IHA, if it is about IgM, IgM is the cold type of antibody, which, for example, in cold agglutinin disease or cold IHA, they react best at the 4 degrees Celsius, right? Direct home test, of course, positive with IgG plus. And for cold IHA is the C3D complement. And auto antibody specificity, warm IHA, this example of antibody involved, could be a rhesus antibody. And for the CAD, for the cold IHA, anti-BI. Mechanism of hemolysis is from FC receptor mediated, and for the IHA, it could complement mediated. In vivo hemolysis, warm IHA usually occur extravascular in the spleen, and CAD inside the blood vessel, and RBC is sequestration happen in spleen for warm IHA, and liver or in the cold IHA. So the main point here is the cold IHA involving IgM and C3D and best hemolyzed at 4 degree, and warm IHA involving IgG and best react at 37 degree. So from this slide, if patient having cold IHA, of course you need to warm the blood if patient need transfusion, and you need to blanket the patient, make it warm. Don't put aircon because it best react at a full temperature. So the causes, when you see IBP, warm IHA, you need to find the causes. It could be from the, like I said, lymphoproliferative disease like CLL, Hodgkin disease, neoplastic disease, autoimmune, underlying, perhaps patient already have autoimmune disease since young, like SLE, rheumatoid arthritis, Crohn's disease. All these can induce autoantibody. And certain viral or bacterial infection also can induce, like HIV, Clostridium bacteria, and also vaccine. Certain vaccine can induce IHA. So this is the common laboratory findings, same as what we talked about, right, just now. And the therapy is usually self-limited, do not require transfusion. If patient needing transfusion, it's quite difficult to find compatible. And other therapies that is given is immunosuppressive drug, cytotoxic drugs, splenectomy, rituximab, IVIG, high dose intravenous immunoglobulin, and also plasma exchange or plasmapheresis. For the cold IHA, like I said, this is the picture of the what we see earlier just now. There's like macam anggur, grape, all bergumpal-gumpal. So usually it happens in the older age, in women. So in the IBP, of course, and you see marked MCV and pH value. And as I say, DAT will be positive and mainly complement, and IgM is the antibody involved. Okay. So antibody screen usually positive. And if the involving allo antibodies, you can do auto absorption technique lah in the blood bank. These are all the techniques lah, which I'm going to not to talk in detail because this is just an overview. So the therapy is you need to keep extremity warm. If involving the lymphoproliferative disease, of course you need to treat the underlying disease with chemo. And you can also do plasma exchange for acute hemolytic episodes. It's only effective for short term to remove the cold antibody. For the mixed type, you also have cold and warm, with presence of warm Ig autoantibody and co-reacting IgM autoantibody. So both have high titer and high thermal amplitude. And fatal cases, we don't know the causes. Usually it's associated with lymphoproliferative, autoimmune, or HIV. Okay. Most patients respond to corticosteroid without transfusion. So mainly for IHA, you need to find fully compatibility testing if patient needed transfusion, and like ABO, you need to find ABO results or antigen K matched red cell. Usually this is mean antigen lah. Blood warmer for transfusion in cold IHA, and HB value between 4 and 5 was the best transfusion threshold. Do not wait for compatible blood because it's very difficult to find. Do not wait for underlying allo antibodies to be worked up when the anemia is severe and life-threatening. And usually, if it's life-threatening, you transfuse with least incompatible. Sometimes you cannot find perfect compatible blood. So you transfuse just to save the life, right? So in general support in IHA, you give VTE prophylaxis because we're afraid of thrombosis, and it's indicated in all patients, and HP less than 8.5 despite ambulating well because there's a risk about 20%. And proton pump inhibitor is indicated in high risk bleeding or elderly because it can give ulcer stress, and also you can supplement with folic acid and beta. Okay, for drug induced, this is a quiet cause, but not all individuals prone to have hemolysis taking the same drug. Because certain individuals also have maybe genetic predisposition that are fragile for them to take certain drug. They can hemolyze, but not all develop the same symptoms. Okay, so this is the most commonly implicated drug like antimicrobial like cefotaxime, ceftriaxone, piperacillin, beta-lactamase inhibitor. So this is the percentage of patients having hemolysis. NSAID, diclofenac about 60%, antineoplastic chemotherapy, fludarabine, oxaliplatin, 30% having hemolysis, and also antihypertensive and diuretic. So this is the 4 mechanisms of the drug-induced hemolytic anemia, which it's not that important for you except for master level. And orang kata apa, ciri-ciri drug-induced hemolytic anemia ni usually occur 7 or 10 days after patient consume the drug. And when you suspect, you need to stop the drug immediately. That's the first step you need to do. And usually it resolves within 1 to 2 weeks of drug discontinuation. And most cases have positive DAT and be confused with idiopathic warm IHA or hemolytic transfusion reaction. Okay. For the alloimmune, it's more towards the, due to the transfusion of blood, and antibody develops to the RBP antigen that the individual lack. So they produce allo antibody that attacks the RBC patient. Okay. So the result of hemolytic result of interaction of foreign non-self antigens from the donor blood on transfused RBC and patient plasma antibody. So there's a immunologic destruction of donor cells. Kejap immunologi nanti ajar So it could be the immediate type, which involving IgM, which occur within 24 hours and involving intravascular hemolysis, and also it could be delayed, which involving IgG. Usually this is occur later lah, about 1 week or 2 weeks after transfusion, and this is extravascular hemolysis. And this is the difference between acute and delayed. Yeah. The underlying cause for acute usually ABO antibodies. For the delayed, it could be other type lah, like rhesus of the kids group. Hemolysis is intravascular, delayed usually extravascular. Symptoms, fever, chills, back pain, hypotension, pain at site of infusion. This is the symptoms that the nurses need to check every 15 minutes or 20 minutes when patient transfuse. Delayed is uncommon present symptoms. For lab findings, of course, you see all the hemolytic workout will be positive and delayed positive DAT, and you can antibody is you can evaluate the antibody if you want to detect antibody in the delayed time. So for therapy, you terminate transfusion for acute and supportive care. For delayed, usually no treatment needed. And lastly, the hemolytic neoplasm of newborn usually is due to the fetal maternal blood group incompatibility. Mother form allo antibody against the fetal RBC antigen. So IgG is a small molecule which can cross the placenta and destroy the baby's red blood cell. Okay. So the incompatibility can be in 3 categories, like rhesus caused by the anti-D, ABO caused by the anti-A or anti-D. Others are caused by antibody to other blood group system antigens lah, like Deldafi, contoh. So this is the table to illustrate the differences between each causes. Alright, so this is the 4 conditions must be met lah before the HDN occur. Mother must be sensitized to RBC antigen that she lacks. Fetus must possess antigen to which mother has been sensitized. Mother must produce antibody to foreign antigen, and the mother's antibody must cross placenta and enter fetal circulation so that they can attack the fetal RBC. Okay, what the lab test done for the mother, we do RBO reserotyping, antibody screening to detect what antibody is there, and baby with the ABO and reserotyping, and direct test to detect what is the antibody inside on the RBC membrane, and we need to evaluate it to identify the specificity of the antibody. So in the ABP, you can see macrocytic or normocytic blood cell, rapid increase due to response of the hemolysis, and leukocytosis is essentially neutrophilia, right, with blood shifted cell and also an RBC. Okay, for the rhesus causes of the HDFN, there will be marked reticulocytosis, mild poikilocytosis of the RBC, and mainly spirocytes. Increased bilirubin and positive DAT is the typical lab investigation positive in hemolytic workup lah. Okay. So in rhesus, if you want to know whether it's the ABO or rhesus, usually in rhesus there are more spirocytes compared to the NRBC. But if it's due to the ABO incompatibility, the IBP usually show more NRBC compared to spirocytes. Okay. So the therapy is to prevent hyperbilirubinemia and anemia. Usually you can do intrauterine transfusions. And after birth, you can go water therapy to reduce bilirubin. And if it's bilirubin is rising, you need to do urgent exchange transfusion. We need to take out baby's blood and infuse with the fresh blood. And rhesus immunoglobulin, ROGM, there's a passive injection that contains anti-D that prevents maternal immunization. This is in cases if the mother is rhesus negative. You given at 28 weeks of gestation following birth to rhesus infant positive. And the dose, how many doses to give ROGM depends on the Clare-Howell test, Rosette test, or cytometry, which is available, which one is available in your institution. That's all in overview because it's only like 1 hour. I try to hurry up time. Okay, boleh tengok soalan tadi tak?
Okay, thank you. Terima kasih Dr. Hafiz. Dekat chat box ni ada beberapa soalan. Okay, mungkin first kali oleh Dr. Emmanuel. What is the specificity and sensitivity of the mentioned biochemical and immunological tests in IHA diagnosis.
Okay, when you talk about how many percentage of specificity and sensitivity uh, of the test, I don't have the value of the specificity and sensitivity, but usually in IHA diagnosis, like I say, you say biochemical and immunological. Like biochemical investigation, we send LDH, we send urine for hemosiderin, haptoglobin, everything is a standard test in medical laboratory test. When depends on the normal range, if it's high, it's high. So you need to correlate if the hemolytic count is matching with hemolytic uh, suggestive of hemolysis. Of course, you need to correlate back with the clinical. If patient having jaundice, you know, uh, fever, unstable vital sign, you need to correlate with biochemical and immunological tests. You need come together. You cannot interpret the biochemical and immunological tests alone. You need to combine with physical and history so that you can have an overall view. So that's how in clinical setting we manage patient, right? So of course the specificity and sensitivity of the test, like for example DET, right? Of course it's being tested before first by quality control, by control quality control in the lab before we take the patient sample. So when it's working all within quality control all pass, then there's no question about the value of the result. If it's high, then it's high. If low, it's low. It's just that you need to correlate it with physical condition and clinical symptom of the patient. You need to correlate with clinical. You need to interpret it together to come with a diagnosis of hemolysis. Like for example, like certain cases DET is positive, but other investigation like biochemical and clinical doesn't show hemolysis. So meaning DET is not significant. It might the positive of the DET might be caused by other causes which is not significant. Boleh tak? Menjawab tak soalan tu?
Okey ke Dr. Emmanuel?
So soalan
Ataupun nak
apa?
nak perspektif daripada blood bank?
Ah, Mbak Ben boleh juga nak jawab.
Okey, saya sikit je lah saya sentuh ni. For the DAT, direct anti-globulin test, macam yang previously Dr. Hafiz mention, dia detect antibody bind to the RBC in vivo, dalam badan. So, in population, kalau kita cakap tentang hospitalized patient, previously documented about 1 to 15%, 15% patient hospitalized ada positive DAT tanpa ada simptom hemolisis ataupun sign ataupun investigation dia menunjukkan dia ada hemolisis. So maksudnya dia non-specific protein bind to RBC. Tapi patient tu tak ada pun hemolisis. Dia punya frekuensi ataupun prevalence lebih kurang 1 ke 15%. Sebab tu macam Dr. Hafiz mention earlier, we need to correlate with the history and other lab parameters. Itu untuk general hospitalized patient. Tetapi untuk blood donor yang sihat ni pun ada juga yang positif DAT tanpa hemolisis. Incidence dia sangat rendah, maybe less than 0.01% lah. Tapi donor tu tak ada apa-apa masalah. Okay. So kita pergi kepada soalan yang kedua oleh Dr. Emmanuel. How will the current lab test discriminate between cold IHA and warm IHA?
How well do the current laboratory tests discriminate between cold IHA and warm IHA? How well do current laboratory tests? Well, from the slide just now, kan, kita ada table yang between cold and warm IHA. Like I see lah, there are list of laboratory tests you need to do. You cannot rely only one test. Like you have You have full blood count, you have FBP, you have biochemical investigation involving the urine hemosiderin, urine hemoglobin, you know, LDH, serum haptoglobin. What else? DET test. So this is the list of hemolytic workup tests that you need to do, right? So to differentiate them, there are differences in the table just now. Like if you DET, for cold usually it's IgM, for warm it's IgG, right? So for other tests like biochemical tests, usually they are the same, right? LDH would be high, you know, haptoglobin will be low, so indicating there is a evidence of hemolysis. So how to discriminate is between usually depending on the first the clinical presentation and also the direct test and other tests that you suspect lah. Maybe for example PCH, they have different tests, right? To see you know, to support the diagnosis. I tak tahu jawab ke tak soalan tu. Jawab tak soalan tu?
Dia menjawab lah if I think if okay ke Dr. Imada? If we look at the overall pictures, then we have to lump sum the presentation, lab investigation, semua baru kita boleh diagnose seseorang tu as hemolytic anemia. So maybe another question ni, how is hemolytic anemia inherently different from other types of anemia? Kenapa hemolytic anemia ni berbeza dengan jenis-jenis anemia yang lain?
Soalan ni inherently, the keyword is inherently. So
Inherently.
you mean inherited hemolytic anemia ke different with other type of anemia? Is it like that? Ya, I faham macam tu lah. I faham Dr. Emmanuel tanya pasal inherited
Inherited, inherently,
kan? Okay, how is inherited hemolytic anemia different from other types of anemia? Okay, alright. Tadi kita kata kita ada dua kan? Satu inherited, satu acquired, right? How they are different, okay? Kalau yang genetic ni, genetic disorder ni, dia inherit from mother or from the parents, okay? Like for example, hereditary spherocytosis, you should see banyak spirocyte dalam ABP, okay? So this abnormal RBC is abnormal, so they can cause anemia lah because it's not normal. So they are having short survival time. Like for G6, for example, G6PD deficiency, when they have it, they only hemolyze when there is an insult to it, right? If there is no insult, they will be normal. They will be like you and me, can you know, do daily activity. And for the other type is the hemoglobinopathy, right? The sickle cell. Sickle cell also it's normal if there is no insult. But for the acquired cause, you have something that, you know, causing hemolysis directly. Huh? So when you have, like for example, bacteria infection, right? Malaria infection, uh, you have malignancy, lymphoprotective disease that can expose to hemolysis. But bear in mind that not all lymphoprotective can cause IHA, but some of the patients of lymphoprotective or malignancy can cause IHA. But not all patients will present it with IHA. But when you see IHA, you need to investigate the cause, the listed cause that I mentioned just now in the first slide. Especially in elderly, you need to work out for malignancy lah. Boleh faham tak soalan tu? Sama faham tak? kalau sama faham tu, okey lah kot.
Dr. Hafiz, actually, so what I was trying to ask is how is it mainly different inherent to maksudnya, how is it different from other type of anemia?
Oh, ada type of anemia. Okay, ada type ni macam contohnya IDA ke? Macam iron deficiency anemia,
How is it different? Because it's a very specific type of anemia kan? So how is it different?
Okay, contoh contoh macam nutritional deficiency contohnya you lack of iron or B12 folate, right? Usually you macam contohnya IDA, you have hypochromic microcytic anemia. The RBC is low with small and with small RBC. So this is IDA. So in IDA, usually they are not hemolyzing. The RBC does not hemolyze. Okay. The name is hemolytic anemia, means something is hemolyzing. So bila hemolyze, of course it will reflect in the biochemical investigation, especially the biochemical, high LDH, low serum haptoglobin, everything. But this parameter would be not same in cases of IDE because it's not hemolyzing. So that's the difference between these two, right? Because in IDA, you are only lacking nutrients. You only lacking batu-bata nak buat RBC. So patient having anemia because lack of nutrient to build the complete RBC. So patient also having symptoms of anemia, same like hemolytic anemia, with shortness of breath or something like that, lethargy. But the vital sign, if not severe, will be not normal lah, not as severe as hemolytic anemia. Hemolytic anemia, when it's severe, your vital sign would be kacau bilau juga lah kan, will not stable. But in IDA, it's like chronic process, it's not abrupt. So the body tolerate itself with the anemia over time. So they don't have symptoms as much severe as hemolytic anemia. But commonly in IDA, usually they have mild anemia, mild fatigue, mild lethargy, things like that. So to answer the difference, it could be from the symptoms itself. It's not like as severe as hemolytic anemia, and also from the biochemical investigation, which you can detect the difference.
So in conclusion, the difference is we have to look back at the pathophysiology lah. Hemolysis meaning the RBC lies, pecah. So the other lab parameter pun akan affected. Maybe we go into the next question or maybe the last question. Okay. From Prof. Naraza, do you expect to see lineage dysplasia with without plus in the peripheral blood film of patients with IHA? If there is, what's your differential diagnosis?
Oh, ni soalan dari pakar kita. Okay, soalan ni advance sikit lah kan. Okay, do you expect to see lineage dysplasia with or without blood in the patient with
Kalau IHA, tiga-tiga WBC, RBC, HB tu tak okey, tak normal. Ada ataupun tanpa blast immature WBC.
Okay. Okay, macam kita kata tadi lah kan, IHA ni is just a presentation. When there is a presentation, we need to find the causes. The causes could be lymphoproliferative disease, malignancy, okay. So you need to trace back what is to look really hard. What is the real causes of the IHA? IHA is just a presentation. So when Prof asks about lineage dysplasia with without blood in the IBP, is most towards MDS, right? So MDS also might or might not present with IHA. So when you ask me what do you expect to see, I would say that it depends on the underlying disease of the patient. If the criteria of MDS fits the diagnosis of MDS, then it's the diagnosis is MDS. And IHA is just a presentation. It could be or it could not be present. For me, I think that is the answer lah. Bukan nak kata bila IHA wajib nampak lineage dysplasia, no. IHA is just a presentation. The dysplasia is more towards MDS. Like IHA also can present in CLL. You don't expect lineage dysplasia in CLL patient. You see full matured lymphocytes, matured lymphocyte in the IBP, right? So you don't see dysplasia. So it depends on the underlying illness again.
Okay, Dr. Hafiz. Ke nak ambil the last question? Yang last kali, genetic testing role in hemolytic anemia.
Genetic testing role, mana soalan mana? What is your
Sekali.
comment on genetic testing in hemolytic anemia? Genetic testing in hemolytic anemia, genetic testing.
I think this is based on the causes that already
Yeah.
mentioned kan. Contoh
Yes.
kalau thalassemia, boleh lah genetic testing.
Betul. But this is again, you have to correlate back with history, investigation, and other investigation. When you do not find the causes, the correct cause, you don't know cause, and you might thinking this is might be due to inherited causes, like for example genetic, right? This is PD ke, thalassemia ke, especially the 3 gene deletion in alpha thalassemia also can cause hemolysis when there is an insult. So maybe can use that. Molecular for alpha if you suspect alpha lah, but this again need to base on the physical history and also full blood count, whether you suspect it having it or not. And sickle cell also lah, right? If you do HP analysis and can proceed molecular if you have it.
Okay, yang the last tu, I think the use of targeted NGS in anemia panel. Itu mungkin a subset of tests that maybe we can actually explore further lah kan. NGS in anemia panel.
Yeah, this is like quite advanced. Well, to be honest, I'm not familiar with NGS. Even we don't have that I don't have that yet in my lab. So I think yang tu can be explored as a research, Emmanuel. If you want to have a algorithm, if you suspect something genetic, you can proceed with NGS.
Okay.
Yeah.
Saya tengok kat chat box ni dah tak ada soalan. Jadinya sebelum kita ada apa lagi ke soalan oleh para hadirin di online? Okay, calling one, twice, tak ada. Okay, kalau tak ada, saya mohon untuk para hadirin semua untuk mengisi borang kehadiran pada link yang telah diberikan. Klik kat situ, isi borang kehadiran. Okay, supaya kita dapat capture lah siapa pihak yang hadir, siapa yang tak hadir. Okay, saya rasa mungkin kita boleh sudahi kita punya sesi perkongsian hari ini. Okay, terima kasih diucapkan kepada Dr. Hafizudin serta para hadirin, our attendees. It has been a very useful session, I believe, to all of us. An eye-opener, especially in approaching patient for hemolytic that has suspicion, that we suspect to have hemolysis anemia. Okay, hemolytic anemia. So, kalau dah tak ada soalan, jangan lupa untuk isi borang kehadiran dan kita mungkin boleh akhiri kita punya sesi perkongsian kali ini. Okay, terima kasih semua. Jumpa lagi dalam sesi yang akan datang.
Terima kasih.